morning. Good morning. Thank you to the team and staff of this phenomenal organization, Fourth Trimester. Let's give them a hand clap, please. Woo! The work that they are doing to build community and awareness around families and post-birth is simply incredible. Thank you also to the Idea Museum for giving space to parents to come and learn and grow and share here. I am Monique Norington-Joseph, and I am the founder and director of Urban Mommy Inc. We believe that when you invest in mothers, you will definitely build families. It is indeed a privilege to be here with you all today. So for the next 50 minutes or so, we're going to get a little comfortable and a little cozy with each other. I want to introduce some of you to some cultural celebrations of building community that we have in the African American community. So there's going to be a lot of look at your neighbor and say after me, a little stand up and go hug someone. These are just little Black people cultural appropriations that we've created in our community. So let's get started. Everybody stand up. Go talk to someone that you haven't met today. And tell them that I'm so glad that you're here today. All right. Thank you so much for participating. So I am a mother of a beautiful little passionate, funny, super intelligent 6-year-old named Zoe. And I'm married to one funny, loving man named Sheldon. I'm like every other parent in this room. The moment that we learned that we were having a child, we were simply elated. We started planning her entire life. The hopes, the dreams, the expectations. I became obsessed with buying little girl shoes and little hair bows. I immediately started to plan her colors of her room and everything in between. I was elated. I was finally pregnant. I was 37 years old, and I was about to have my little bundle of joy. While my flights of fancy were over the top with all things little girl, little did I know, brewing at the same time was a healthcare crisis that would forever rock my world. Little did I know that at that time, as an African American woman, giving birth could actually mean me dying. Unlike probably about 80% of the women in this room, I entered a pool of statistics of African American women that are 3 to 4 times likely to die during delivery or after childbirth. And according to the World Health Organization, the odds of surviving childbirth are comparable to women in third world countries, where significantly proportions of them live in poverty. So look at somebody next to you and say, how is this possible in the country that we live? Look at somebody and say, how is this possible in the country that we live? I'm glad you asked. The U.S. has a higher rate of maternal deaths than any other developed country in the world, with 26.4 deaths per 100,000 births. The Centers for Disease Control Prevention estimates that 60% of these fatalities can actually be prevented. As I mentioned, Black women are 4 times as likely to die from pregnancy-related causes than white women, and an additional 500,000 women experience life-threatening postpartum complications. So why are Black women like myself at such high risk? And why aren't some healthcare professionals responding? Well, it was Christmas Eve, 2012, and my husband and I were enjoying a Christmas Eve celebration with some friends. I was about 10 weeks pregnant, and I had a sudden urge to go potty. Yes, I still say potty. I have a 6-year-old. I went to the bathroom, and sitting in my underwear was a huge blood clot, and I was still bleeding. I left the bathroom calmly. I gave my husband that look. Y'all know that look. He looked around the room. He excused himself. He grabbed my purse, and we left and immediately went to the ER. Immediately went to the ER. I remember that weekend like it was just yesterday because it was super traumatic for me. When we arrived to the ER, I told them that I had been feeling a lot of heaviness in my vaginal area and some cramping. The attending physician looked at me and said, "That's normal. Many women my age will just simply pass the fetus." I simply could not believe what I had just heard. I was angry, I was mad, and we both looked at each other like, "That's it? That's all you have to say?" I thought to myself, so I'm supposed to just go home and just wait for my child to die. I refused to accept that logic, and I refused not to be heard. The very real health concern I was expressing about my health and that my child was actually being ignored and simply boxed into an approach instead of looking at my entire history. They didn't even ask me about my history, and this was in ER. See, that was also part of the problem. I was a new mom. I had no history of pregnancy before, and I had no issues that were lurking. There was an automatic assumption that was made, and it was treated as such. It makes me wonder, is there a fine line between clinical opinion and intuition and unconscious bias? Again, without knowing all of the statistics and being impacted as a Black woman in her 30s and pregnant, I refused to allow that provider to just give me any answer. We went home that evening not knowing if our child was going to survive the night. What physicians didn't know at that time, because I wasn't actually checked out, was that I was actually already dilating. My blood pressure was increasing, and I was developing challenges that could end my life and my child's life. Armed with only my will to survive, I was determined that this baby was going to survive. Yes, faith and prayer was a part of my strategy, but also an uncompromising fight to get the best health care and doctors in place to have a safe and healthy pregnancy. See, I was fortunate, so I thought. I'm educated, living a middle-class lifestyle, no major health complications. I thought maternal health care complications were only for mothers who were experiencing life-altering issues like asthma, diabetes, living in poverty, added stress. But the reality is that Black women and their heightened risk of pregnancy-related deaths spans income and education levels. So anybody can be impacted. For example, shortly after giving birth to her son in August of 2017, 27-year-old activist, Black Lives Matter icon, Erica Garner, suffered her first heart attack at 27 years old. Garner, who you all may know, her father was Eric Garner, who was choked to death by police. She had an enlarged heart. The stress of her pregnancy and perhaps the strain of her father's death further weakened her heart. 4 months later, she suffered another heart attack. This one put her into a coma, unfortunately. On December 30th, 2017, Erica died. Serena Williams, you all know her, powerful tennis player, nearly died from pregnancy-related complications that she too reported to her physicians. Beyonce Knowles, Michelle Obama, the list goes on and on and on. The one common thread is that we all share racial and gender discrimination. Now, look again at your neighbor and say, we have to do something about this. We have to do something about this. So am I saying that bias and discrimination in daily life affects the African American woman? Yes, I am. Every woman who has every resource available to them and at their disposal still runs into life threatening issues. Research has shown us that stress induced by discrimination plays a vital role in maternal mortality. In my own case, by the time I connected with a high risk maternal fetal hospital, it was too late to give me the much needed cerclage that I needed to reinforce my cervix during my pregnancy. So now, not only was I already 4 centimeters dilated at 16 weeks, I was now showing signs of preeclampsia and also stress. My stepfather at the time was also dying, so they were concerned about that. The stress I had now developed from having to advocate for my own health care, defend my symptoms, along with my daily strains, was beginning to really take its toll on me. So I want to pass around, if someone could help me, with some of the risk factors that affect African American women. This sheet that's being passed around shows some of the risk factors that affect African American women across the country. What we know through research is that African American women with increased exposure to stress throughout their lifetime increases the wear and tear on their body, which increases their risk of maternal and infant mortality. So this is really heavy stuff. What do we do with all this information? And how do we begin to create community and advocate for ourselves and heighten awareness? Take a minute and look at those statistics. Now look at the person next to you and say, I am my sister's keeper. I am my sister's keeper. There are movements all over the country now and advocates like myself, practitioners, and policymakers who are leading efforts, thank you, to raise awareness and to address the critical state of mortality and infant mortality as it relates to African American women in the United States. I am proud to announce that Urban Mommy and our Make Humans campaign has partnered with the Black Maternal Health Caucus with Congresswoman Alma Adams and Congresswoman Lauren Underwood to introduce a congressional bill to the 116th Congress entitled Black Maternal Health Monibus Act 2020, which seeks to end maternal and severe mortality in the United States and close disparities in maternal health outcomes. So excited. Yes. Thank you. Thank you. So, what can the healthcare community do to end these racial disparities? First, we need to recognize that there are disparities in maternal and infant mortality that is rooted in racism. Structural racism in healthcare and social service delivery means that African American women and women of color can and will receive the best care. First, we can improve access to critical service and health coverage by strengthening existing programs that already exist. Screen and treat women at risk. Like myself, when I walked in, they just assumed they put me into a pile and just assumed that, I was being treated a certain kind of way. And I had risk factors that were already there, that existed. Offer African American women tools to navigate the healthcare system. Second, improve the quality of care, patient-centered care that is responsive to the needs of Black women. Things like training providers to address bias in their healthcare. Create some standardized assessments for mothers and infants. And third, enhance supports for families before and after birth, and to also improve data and oversight. And my personal favorite, address the social factors of health. These are the conditions under which African American oftentimes live, work, and play. For Black women, structural inequalities, chronic stress from poverty, discrimination on the job, bias are shown to have a declining impact on maternal health. There is so much to be done, everyone. We know that without healthcare, policymakers and advocates working together, we can address all of these issues. So, how do you begin to advocate for yourself? I have one more sheet. Thank you. How do we begin to advocate for ourselves? These are some of the strategies that I took, that I learned from, that I often advocate with other mothers that I run into. First, it's communication and being prepared. You don't need to feel intimidated by the medical providers. They work for you. And when you have common ground in these relationships, it's your health, and it is in your best interest to be as empowered as possible. Start with making a list of all your symptoms and questions. That's one of the things that I did. Only you know your entire history. They can't help you if they don't know you. So don't be afraid to tell them absolutely everything, from the embarrassing to the not so pleasant. Write down your medical history. It really and truly might make a difference. Do your research. I know some practitioners hate Google. They hate for people to come in and they say, well, I Googled this, right? But you have to be an informed patient, and you have to be an informed health consumer. Seek out information about your condition if you know it. Choose a doctor, a pharmacy, a hospital that you are comfortable with. Seek more than one opinion. Pay attention. Pay attention to your body. If something doesn't seem right, bring it to the attention of your provider. I didn't stop. A real quick story. So I own my own business as well too, a public relations company, and I was actually in talks with that particular hospital. But none of the physicians in there, they knew that I was there as a patient. And so I had a situation, unfortunately, with the anesthesiologist when I was actually 78 hours into delivery and my epidural slipped out. And so he was the only one on staff at the time. And so it took some time for him to actually come back and to reinsert it. Well, by the time he made it back, he was quite agitated because I had a lot of questions. And he didn't think that he should be answering those questions. And so he made a snide comment to me and he said, well, you know, larger women, we have to take time, extra time. So I looked at my husband and I said, hand me my phone. And so while he was literally in my back, I was texting the vice president of the hospital. And so at that very same moment, now I'm not saying everyone's not going to have that kind of access, but the point of the reality is that you have to make adjustments and meet as many people as you can. Needless to say, they sent another, in fact, I started hollering and screaming because, of course, the real pain kicked in. And they sent him out and they sent another anesthesiologist. And the comment that he made was just deplorable. So don't give up. Don't settle. Only you know your body best. If you're feeling something isn't right, you have to speak up. I found that the harder you push for answers, the more answers you will find. Get creative. Find the help that you need. Again, practitioners often don't like Google, but I enjoy Google because oftentimes they Google as well too, right? So it can be your best friend. You can track down emails, phone numbers of a lot of practitioners. Make sure that you communicate and use your own voice. Seek to build relationships. That's a big part of your journey, is building relationships during your pregnancy. At some point, that may actually pay off. The healthcare system almost failed me, and it's failing, unfortunately, a lot of Black women across the country. African American women deserve to have a safe and healthy pregnancy and childbirth. We need systemic change, improved healthcare, and access across the board. I need each of you to join me in advocating for Black women to achieve their optimal health and health care throughout their lifetime. We all deserve a fighting chance to have a safe and healthy pregnancy before and after birth. Thank you so much. So now, I have a very special treat for you guys. I've invited two outstanding African American women healthcare practitioners to join us here in Arizona who are leading the charge in advocating for women's health and research in medicine and sharing their practices. First, I'd like for Dr. Michelle Mix to join me here at the podium. Dr. Harris is an interventionalist cardiologist who specializes in women's heart disease, congestive heart failure, and much, much more. Please welcome Dr. Mix. Excuse me. Secondly, I'd like to welcome Dr. Tracy Fitzhugh. Dr. Fitzhugh is an obstetrician gynecologist who specializes in pregnancy and childbirth and women's reproductive tract. Please welcome Dr. Fitzhugh. All right. You sit right over here. Okay. Thank you, ladies, for joining us.
Good to be here.
Doctors, we will begin with a few town hall-like questions, and then we're going to open it up to the audience. So let's begin by you sharing some of your background and then what your experience has been working with women who have come into your office pre-pregnancy, pregnancy, or post, who are considered to be in the high-risk category.
So I'm a board-certified obstetrician gynecologist. I've practiced around the country in a variety of settings, from urban to rural to suburban, major health centers we categorize based on the level of the NICU facility. So level 3 NICUs, and then in urban and rural settings, just well baby nurseries. And first of all, I chose women's health and obstetrics and gynecology in particular because I feel that women are the gatekeepers to the health and well-being of their families. We make humans, so from birth throughout the lifespan of our families, we're the ones who take charge, typically. We are the feeders of our families. We are the teachers of our families. We are the appointment makers and the appointment keepers of our families. And so I like to be a partner in that. My experience is I currently work as a hospitalist, an OBGYN hospitalist. So I work in hospitals and I stay in-house for long shifts. The idea being it's a patient safety issue, and safety and quality are some of my passions with regards to healthcare and in particular obstetrics. So you don't know this, but some hospitals you go to, if you come in, your doctor most likely is not there because they don't just sit there waiting around wondering if you're going to come. And babies don't typically make schedules when they want to come. So some hospitals now are starting to have what we call an obstetrician gynecologist hospitalist. That's a doc in the box 24/7 that's available for emergencies, like you come in and you're one cheek on the wheelchair, huffing and puffing, and the baby's kind of crowning at your, yeah. So we're there for that. We're also there for those unexpected emergencies. You've got a beautiful heart rate and that baby's doing great and it's a normal healthy pregnancy and a normal healthy labor, and then suddenly something changes. And I'm the person who's on the boots on the ground, in-house all the time to help your doctor. Sometimes if your doctor's not there, I step in, and if your doctor is there, then I assist to make sure that moms and babies have healthy experiences for delivery and even before delivery.
Thank you.
Mm-hmm.
So I am a board-certified interventional cardiologist, and interventional means I have the pleasure of getting up in the middle of the night and putting in stents when patients have heart attacks. I'm actually the only African-American female in the entire state that does this. It's a pretty tough job, if you can imagine. And so the way I become involved is pre-delivery. So when high-risk maternal fetal medicine physicians or OB-GYNs say, we got to take a look at this patient's heart. Maybe the heart rate is up. Maybe they have a history of heart disease. Maybe they just got diagnosed with gestational diabetes. Usually those patients will come into my office and we'll do like a pre-delivery workup. What does that mean? That we usually do an ultrasound of the heart, just make sure the structure and the function of the heart is okay. In some cases, we have patients who've had what's called pericardium cardiomyopathy before, and then the OB-GYNs will want to make sure that they are fit to deliver again, and fit meaning do they do a vaginal delivery versus a C-section. So I help kind of guide the physicians to which delivery method would be the best for the patient. So, and the reason I have an interest in this is I had my own troubles, as Monique did, with delivery, and I was on bed rest 2.5 months prior to, and that was during fellowship. So it was a pretty tough time. So, and a lot of cardiologists don't want to touch these patients. That's the other reason. They're very scared of the medications and the babies, and so I've kind of found a niche with it because of my level of comfort, and especially with my own past experience. So.
Thank you. In your opinion, what can a medical community do to increase awareness and tackle this epidemic and maternal crisis with African American women?
I feel like one of the biggest issues is just collaboration. Your relationship with your OB or midwife or whoever is your healthcare provider during your pregnancy and even before should be a partnership. It should not be that person talking at you and or you talking at that person. There has to be a lot of direct and open and honest communication about your history, about what you're willing to do and what you're not willing to do. I can't tell you how many times I've had conversations with patients and they, the whole time, just smile, yep, we're gonna do it. And then they leave and then they had no plan to do anything that we talked about. And so it has to be an open and honest communication and collaboration, and then education. Patients need to be informed. They need to be informed of their rights. They need to be informed about their bodies. And symposiums like this are great opportunities to learn about what to expect during pregnancy and beyond.
I would say education. And doing my own research, the patients who have preterm deliveries, those patients are increased risk of cardiovascular disease. And so my effort and my practice has kind of shifted more to this just because of the patients that are coming in that want, they have families or family members or friends that have had heart attacks. They don't want to be in that same situation, so they want to come in and look at preventative measures. And so I think it's the same, especially in African American women who are pregnant. We have to know that they are increased risk of preterm delivery, increased risk of gestational diabetes, increased risk of hypertension long term, and also increased risk of mortality down the line due to an increased risk of coronary artery disease. And so we got to talk about diet. We got to talk about exercise. Those are two of the big things during pregnancy that can make the outcomes worse. Also, weight sometimes is an issue. That was one of the studies found that the average BMI in African American females when they're pregnant is larger. We're larger than our non-African American counterparts. And so I think a lot of education on diet, exercise, wellness, wholeness, decrease in stress is going to be huge. I had no idea the effect of stress on me. When I went to preterm labor, I think I was working probably 2 or 3 jobs. I finished medical school and I was just hustling. I was about to start my cardiology fellowship, wanted to have a child in between. And so I was, doing night shifts here, night shifts there. I was doing all, I was on the go, and I actually filed for divorce during that time too. So it was a very stressful period, but I was very busy. And had I known that, the level of stress that I would be under, what I was doing to myself and my baby, I would have maybe did things a little differently. So
I agree. I was also working on my master's at the time, and I ended up taking a leave of absence during that time because I was put on 6 months bed rest for that. And so I agree. I didn't know as well too. So I would add to that question then, how do we get the information out to women? How do we reach women to get this much needed information to them?
I wish I had the magic bullet answer for that one. I think symposiums like this are great, but sadly, look at all the empty seats.
Exactly.
And I was fortunate enough to learn about this through Monique, but There's so many women who don't. And so as many opportunities to inform and engage and show up and read books and ask people, pursue them. But I'm probably preaching to the choir because the people here are the people who are informing themselves.
I would say telling our own stories. I don't even think you knew my story, and I know you didn't know about what I went through. I've been private about that. I haven't really talked about what I went through during my own pregnancy. So I think first telling our stories, telling our experiences, and then social media. Monique has been helping me with the social media aspect of things, and you just don't realize the reach, especially these young people that are out there on the internet. So I think telling our stories and then social media, getting more involved in social media.
I would also add that being very cautious in the information that you're acquiring, because the reason I don't like Dr. Google is because people will replace the credentials of random Joe on Google and think that they supersede the credentials of this woman who has trained at residency and fellowship and her professional experience as my own. And so Google is a great starting point, so you can figure out where to ask, what questions to ask your healthcare team, but it is not the end all and be all, and you have to be very careful of what sources that where you're getting your information.
Good, thank you. And my last question, and we'll open it up to the audience, is as consumers, I guess you kind of answered some of this, and everyday people, what piece of advice is most critical that we take home with us today so that we can begin to implement immediately as partners in our own healthcare?
Just one piece?
Or a few.
Start early. Start collecting information and informing yourself before you're pregnant, if possible. Start taking care of yourself before you're pregnant. Take those prenatal vitamins. Start exercising. I was older when I had my baby. They call it advanced maternal age or an elderly gravid.
That's not bad.
That's not right.
No, I was older than that. But anyway, I knew that as an older mom, and also as an African American mom, I had a higher risk factor for having hypertension during pregnancy, high blood pressure, having diabetes, high blood sugar during pregnancy. And I also knew my family history. The very first thing I did, and I admit this is a luxury, is I got a trainer because I don't like to exercise. And I knew that I needed that level of accountability to do the right thing for me and for my baby. So I started exercising regularly and ate well. You're not eating for two. You're only eating for one. Most of us eat for two when we're not pregnant, so we don't really need to add on extra calories, just saying. Just saying, including myself. And engage for prenatal care, preferably preconception care, so that if you need the assistance of someone like Dr. Mix, you'll know in advance and you can get the information and the help that you need.
That's the one thing I would have done differently.
Talk to your family. And, I don't know, generations, I think, before us kind of kept their stories quiet, too, of what they went through and what their experiences were and what their medical history is. I have so many patients that don't, you're supposed to fill out that form where the family history is, they leave it blank because they have no idea, what family conditions that run in the family. So
and it's not because they're adopted.
It's not because they're adopted. Exactly. Just that we don't talk enough about what's going on with us. So I would say talk to your family, know what kind of conditions run in your family, so you can be hypervigilant about, especially if diabetes runs in your family. You really want to see that glucose test, and look at the numbers on that and make sure it's not on the high side and you're not at risk of gestational diabetes. And then you can't stress that enough. Diet, exercise, just we think when we're young we can take on the world. We can eat what we want to eat. We could do not exercise what we want to do, but that stuff catches up to you in pregnancy and age. So start young. I didn't do that. I ate crap. I did medical school. I did an MBA. I did all these other degrees, and I didn't take care of myself. I was just going, eating fast food, doing whatever because I didn't see the effects of it. So I would say start early, start young, start eating right now, start exercising now, so that when you do get pregnant, you're ready. And I think that's it.
we're going to open it up to questions from the audience. Please step forward if you could. Sorry about my papers everywhere. Good morning, ladies. My name is Amber Roberson. This is not a watermelon. This, of course, is my third. But I have had many fears and a lot of, and excuse me if my tears fall, I'm hormonal, but I've had a lot of fears with my OB because where I'm at, it seems to be limited as far as the care. But I don't trust my OB anymore because of the things that have been happening with my asthma, the other things that I have. I have lupus, and it seems to look like a lot of the places, because I'm in Chandler, a lot of the places are not considerate of the fact that I'm Black, and that I actually do have a genuine concern. You know, if you're telling me that my placenta is right above my cervix, I'm actually going to be terrified if I see blood everywhere, because I have had 2 extremely rough pregnancies with one really scary delivery with my second child. So it's always a constant thing that is on my mind. It's not just the stress that we deal with. It's the anxiety of being in a certain neighborhood. You do want the best for your children, but being in a certain area where you don't feel like you're getting the care or the responses that you need. And I'm not sure what I should do at this point, because I keep going back. I've had issues where they think I'm just at risk for hypertension. I'm now on 2 inhalers, I'm about to be put on a 3rd. They want me on more steroids. And so it's something that as a mother, you're concerned about your child taking all of that in. And I'm not sure if there's another opportunity or what I do to find those opportunities, to find someone who I feel like is actually listening to my needs.
So I hear 2 things. I hear that you've lost confidence with your healthcare team. That's major. I don't know how far along you are, but it might be time to try to find someone else that you can communicate with. That doesn't mean stop the care that you're getting. Continue that care until you can find someone that hopefully will assume care for you and that you can better communicate and collaborate with. The second thing I hear is that you're scared that the medications that you're receiving are going to be harmful to your baby. And I will just tell you that that's our job. As obstetrician gynecologists, we have 2 patients. It's the mom and the baby. And so we weigh everything as risk benefit, everything, whether or not you're pregnant. We always treat both patients at the same time. In your case, your asthma, if you're not oxygenating well, not getting good breathing well, then that affects your baby. So that's the priority. Your breathing is a priority. And if you're not confident in the care you're getting, then you need to keep talking, keep asking questions, be your best advocate. Don't just take the script for the prescription and then walk away if you're not at peace with it. Ask those hard questions, because otherwise then you go home and you're taking all that anxiety and that nervousness with you. The third thing I hear from you, and this is so common, we just want to write it off as I'm just hormonal and I'm emotional. But really, anxiety, that's real. That is real, and you should not be suffering with that. You don't have to suffer with that. So there are therapists that can help with that. There is medication that can help with that. It can even be safe when you're pregnant. But that level of stress is not healthy for you and or for your baby. And I think that as healthcare professionals, we sometimes take for granted that our best efforts at doing the right thing and helping our patients can also sometimes be emotionally traumatic and harmful from that perspective to our patients. And so if we haven't healed and made peace with our prior birth or healthcare experiences, sometimes we carry that with us to the next experience. And so I am actually trying to change my practice and being a lot more aggressive about encouraging moms to deal with health traumas. It's not that we're trying to hurt them. We're trying to do the very best we can, but those interventions can sometimes feel threatening, and encouraging them to get help and counseling so that it doesn't turn into a PTSD kind of scenario. I'd be happy to talk to you offline too.
I think it's important for you to know that you are the major part of your healthcare team. You can, a lot of people just will come in and leave it up to the doctors to manage that care. No, you are the major, I would say, decision maker. So what you've got to do to make a decision appropriate for you and the baby is to educate yourself. So what you want to ask is, what is the long-term outcomes of these medications on my baby? Is that going to affect my delivery? So just like Tracy is saying, ask questions. And you come in with a list of questions, and until you are comfortable with what their treatment plan is for you, comfortable that it's safe for you and the baby.
And that's very key. Always go with a written list,
Yes.
because as soon as you walk into the door,
Forget everything.
phew,
Yep.
it's all gone.
Yep. And we've developed a comprehensive list of trusted providers, including these two, for the Arizona area. And you can email us at urbanmommyorg@gmail.com, and we can send you that list as well. We cover, all of Arizona. So our list covers the entire state. Mm-hmm. Urbanmommyorg, ORG, @gmail.com. Or you can email that one too. Mm-hmm. Mm-hmm.
And I want to piggyback one more thing. What you want to ask the doctors too is, what can you do to help your situation? So like lupus is a very inflammatory condition, right? So if there's ways that you can decrease the inflammation in your body, how are you going to do that? Diet. But you've got to ask those questions. What can you do as the patient to help your situation? Especially gestational diabetes. People don't want to,
Right.
A lot of people end up with the injections or insulin during their pregnancy. What can you do? Well, look at your diet, look at your exercise. If you don't want to be on the medications, then you've got to play your part. And not to say that you're gonna, that'll always be off the insulin, but maybe you take a lower dose of insulin than had you with the regular diet or not exercising. So,
And part of the reason I created this blog, when I was about 2 months pregnant, my husband bought me a tablet, and I just started blogging about my experiences. And so part of that was because I wasn't finding the information that I needed. And so that blog warped into this, which, we were in Portland at the time. And so we did the same in Portland as we're doing here. And so the information sharing is key. There are people that can help you. You have to do exactly what she said and reach out. Any more questions? Anyone else? Don't be shy. You have two extraordinary physicians here. Now is the time. Wow. Anything else you guys like to add?
No, I'm happy to speak with anyone after.
yeah.
Yes, ma'am.
I don't think it'll reach. I'm sorry. Thank you.
In your experience, have you witnessed or been a part of a health team for a mother giving birth that you felt like wasn't really being collaborative and felt like their, motives weren't really something that was authentic to the patient, or like one size fits all, and just kind of going through procedure where it felt like it wasn't necessary or discriminatory towards the patient? And I guess I would say, and how personally would you handle something like that if you were to witness something like that in your practice?
Yes, is the answer to the question. Certainly, I witness bias all the time. It can be biased, cultural bias. It can be socioeconomic bias. It can be gender bias. I witness it all the time. And fortunately, as the physician in the team, I'm kind of the captain of the ship, just saying. And so, I set the tone. I set the tone for how communication goes between me and the nurses, between the nurses and the patients, between the other members of the other physician members of the team, anesthesia, et cetera. So I try to be open and honest and talk directly with my patients and their families and make sure that they understand and they ask the questions they need to ask and they have time to do so, and set the tone. And sometimes I've had to pull people aside and say your bias is showing. It's awkward. I don't love it. But, we all have to advocate and sometimes do the hard work. And patients have to do the same.
I've had some really tough cases. As a cardiologist, patients can get really sick. I had one patient that was on meth. Her pump function, squeeze her heart, was 20%. Normal pump function is about 65 to 75. So she had what's called meth-induced cardiomyopathy. And she came into the hospital with blood pressures 190s, 200s. And because of what the fear for preeclampsia or eclampsia, the OB team recommended that she consider ending the pregnancy. And I think she was 20, 24 weeks. And so the patient, for whatever reason, felt very comfortable with me and wanted to know my opinion about it. And I that's a tough one for me to tell anybody to the recommendations to end their pregnancy. But I told her the risks. I told the risk involved for her and for the baby. And I told her ultimately the decision was hers. She went through hell. She went to respiratory failure, had to be intubated, ended up on dialysis during the pregnancy. They ended up taking the baby, I think, at maybe 26 weeks, so early. She barely made it through that pregnancy, but she came into my office last week. I'm about to cry on this one because it blew me away. She brought the baby, who was in the hospital, I think, 3 months after. And I didn't even remember this, actually. She told me, thank you, because if it wasn't for you, I wouldn't have my son. And she told me that she remembered me saying that I don't necessarily agree with aborting the baby. So that was interesting you asked that question, because that just happened literally last week. And she has not seen it. She's still fearful of doctors. She's only seen me, and that's not a good thing since she delivered last year. But it's tough. It's tough. I didn't necessarily agree. I understood where the physicians were coming from, because it was tough. She went through hell. But our job is to educate, like I was telling you, is to educate the patient. And the patient make the final decision. But they have to make a well-informed decision.
And that could have ended differently.
Oh yeah.
So that mom made a choice that really she could have died.
Yep. She was close.
Yeah, I'm sure.